Good evening, everybody. Welcome to the Rodham Institute's Impact Speaker Series. My name is Dr. Gigi El-Bayoumi, and I'm the founding director. We have another terrific night of a wonderful conversation with our colleagues about safe babies and safe moms. But before we get into our webinar tonight, I just wanted to give you an update. The Rodham Institute was invited by Ms. Cora Masters-Berry of the Southeast Tennyson Learning Center to co-host a mass vaccination event, which will happen this Saturday. It's just for Ward 8 residents. And what we're doing is we are bringing all of the institutions to Ward 8. Happy to report that my colleagues from not just GW, but from Howard, from Georgetown, MedStar, Children's, United Medical Center, we're all coming together to serve the good people of Ward 8. And the model that we've used is really partnering with all the community-based organizations that are working in Ward 8 because they're the ones that are registering the residents. And then once people come, guess what? They can get free Uber rides, they get free childcare, and we have our friends from the mental health world, the primary care world, the food services world, because we know that people are really hurting when it comes to food insecurity, mental health, and we really want to re-engage people back into care. So AmeriHealth, Care First, MedStar will all be there, which is really kind of a good segue into our topic tonight, because COVID has been horrible. We can see, we hear the numbers of the deaths and of course disabilities, but what we don't think, I don't think what we talk about enough is the collateral damage for other health issues, other illnesses, other normal parts of life, like having a baby, like a pregnancy. How has that been impacted? So without further ado, allow me to bring in our illustrious panel this evening. And you know, I'm a very informal type person, so I'm just going to call on the person and they're going to introduce themselves and tell the title. So I'm going to start off with you, Dr. Thomas, Dr. Angela Thomas. Welcome.
Thank you, Dr. Gigi. I am the Vice President for Healthcare Delivery Research at MedStar Health, and I am the Executive Lead for our DC Safe Babies, Safe Moms program.
So excited about that. And just to tell everybody, the Clark Foundation gave a generous grant to MedStar Georgetown to do this initiative. And one of the things that we're going to be learning about is how this is going to have a positive impact on babies and moms and families in the District of Columbia. Dr. Patchen, welcome. Please introduce yourself.
Thank you. Hello, everyone. My name is Loral Patchen. I work at MedStar Washington Hospital Center. I'm a midwife, and I'm also in charge of community programs and innovative programs around maternal child health. And I serve as the lead for Safe Babies, Safe Moms around issues of maternal health. Really happy to be here with folks tonight.
Thank you. We're so happy they were with us. And then Ms. Quinn, not Dr. Quinn, I was corrected. Ms. Quinn, would you join us, and welcome to the program.
Thank you so much, and thank you for the invitation. I'm Tricia Quinn, and I am the Vice President of Policy and Partnerships at the DC Primary Care Association. So glad to be on the panel with Laurel, who is a partner in so many ways to a range of things that DCPCA is working on. So in illustrious company here.
Indeed you are. And I just want to just sort of say that one of the things about the Rodham Institute is we feel that all institutions should be working together to improve the health of the city. Now, it may be that MedStar will take the lead in the Safe Babies, Safe Moms. It may be that Howard will take the lead in another area, GW Children's, but it's okay to be competitive. But when it comes to the most vulnerable people in our communities, we really need to come together. So welcome. And I'm glad that we're doing this. You know, maybe I'll start off sort of with the midwives first, because I just want to get a better understanding, or please tell the audience, you know, I was born and raised here. I'm of Egyptian heritage. As a matter of fact, my mother is a medical anthropologist. So she did her field work in rural Egypt. So she talked about the amazing things that midwives can do in that setting. And I think that sometimes people think of midwives and the history of midwives more in rural or developing countries settings. I don't think that people actually realize the crucial role that midwives play, and actually better outcomes too than physicians, right? Can we talk about that?
Oh, I'm always happy to talk about midwifery. So of course, you're correct. Midwives do a lot of care throughout the world, including highly industrialized countries where we have really advanced medical systems, as well as those without. In the United States, actually, most midwives work in hospital settings, although midwives also work in community-based settings as well, birth centers, as well as home birth. I think one of the things that's really great about working in DC as a midwife is that we have such a rich birth community in this area. We have midwives that practice in all of those settings. We also have doulas and childbirth educators, as well as lactation consultants that are available in this area. And so it really is very possible to have a full wraparound experience as a mom. We even have doulas that not only support moms during labor, but also that really connect with families and people that have just had babies right around that those early days at home, which are so exhausting, if nothing else, but also, full of all kinds of transitions. And so we really are in this community very fortunate to have a lot of folks in roles that are very supportive of this life transition.
So please explain the difference between what is a doula and what is a midwife. What are the two roles? Because you mentioned a whole lot of different people, but how do they differ? What are sort of each of their skill sets, if you will?
Sure. So doulas are experts in supporting people who are having birth and really focus on the sort of emotional well-being and comfort, as well as, just sort of what is it that the individual needs in the moment. As a midwife, I'm certainly attuned to those things and focused on those things, but it's one component of a range of just sort of activities and elements of the birth experience that I'm paying attention to. So, a more medicalized way to talk about it is that as a midwife, I'm attuned to the birth and sort of thinking about how to support the birth process. And a doula is very focused on the individual giving birth and how to ensure that they have what they need to feel fully supported in the moment.
Mm-hmm. Thank you. And this question is really open to everybody, but I did mention that midwives have better outcomes, right, than physicians. So whoever feels comfortable about, sort of taking that question, because I think, from the perspective, I'm a physician. However, I feel that different clinicians, first of all, we're all spokes on a wheel, right? We're all equal. We all hope to and aspire to take care of the individual, the family, and the community at the center of that wheel, but we're all spokes. So why is it that the outcomes are better? What is it? What is the medical system doing that's maybe not making the outcomes as good if it's a physician that's delivering the baby? Or maybe said a more positive way, what is it that midwives bring that make it so much healthier, both for the baby and for the mom and for the family? Who wants to take that? Dr. Thomas?
I know Loral has the official answer here, but so I'll start. And most of my answer is going to be because I've studied under Loral these issues so well. But I would say this, just as an observer of our healthcare system and having spent a decent amount of my career around the physician element and also learning a lot from the midwife element, I think the start, and then also understanding what people who seek care really are desiring to receive in the care experience. I think the difference in outcomes is that person focus that midwives and doulas bring to the experience versus the act of delivery focus that I think physicians typically bring to the experience. And so focusing more on, you know, if it was me, the Angela in the equation is what midwives do very, very well, both versus focusing on the delivery Angela's doing, that I think that tends to be a default by our physicians, but Loral can expand.
Oops, you muted yourself by accident.
Oh, sorry,
There you go.
I'm
That's
I'm
okay.
backwards. You know, it's everybody says it's a year and still learning how to do this.
Yeah, well, it's the best that we can do given the point. This technology, I'll be so happy when we can actually be in each other's presence. There's advantages to this, but anyway.
It all has a role and a space, but so I think I might go a little bit more population based, since Angela gave such a great perspective on the more individualized care space. But you know, midwives have not been part of the construction of the modern maternity system in large part in the United States. And they were and spent many decades really being sort of outside the formalized growth and sort of advancement of medicine. And I think that's turned into being a real advantage in the current system, because we know that, you know, particularly Black women suffer from the system that we're in. And, you know, I know that for me, one of the things that I try to be really mindful of in talking about the challenges that we have in the maternity system right now is that when we start talking about particular groups of individuals, it can be really easy to sound like there's something about that group that relates to that group having, you know, worse outcomes and things, when in fact, it's the structure around those individuals that's driving the dynamics. And I think for midwives, it has turned into being a real advantage that historically in the recent history, we've been more isolated and outside medical systems. And part of our challenge right now is figuring out how to rebuild the systems and the structures inside maternity care. And as midwives have sort of moved back into the maternity space, I think we're fighting really hard to bring with us the principles of midwifery that are very different, that are part of the reason why we didn't fit in to this structure very easily.
Well,
Loral, I love the idea of midwives as like the radicals and the subversives in a system that just isn't working well for women, and fully support like this struggle to stay that, you know, to stay that radical in the space. And like the arc isn't great, right? In terms of like the ability when you're coming from the outside in, who changes? And I think, you know, kind of putting that flag in the ground to say like we have to stay that radical in the system, because you know the DCBCA did a report in 2018 that used human-centered design to look at what was happening for women of color in the district and how they were experiencing the system that Loral is radicalizing, I hope. And it really, a couple of things came through really clearly, like the system isn't meeting the needs of women of color. In many cases, it has to do with sort of being partners with women. And I think that is the way midwives frame, you know, everything that Loral and Angela have said about framing, how, you know, what are we doing here? And wanting to be in partnership with women who are, or birthing people, versus, you know, you're a patient in my system, you know. And I think what came through in our report was women felt like they were not being heard, they were not being partnered with, they were not being respected by that system. And I think midwives bring that partnership.
Well, we are now talking about disparities in terms of outcomes. And what is sad is that when it comes to women of color, even if you adjust for the education and the socioeconomic status, Black women still have worse outcomes. And for the audience, if you have not read the article from the New York Times, that's probably about 2 years old now. It was in the New York Times Magazine, very well done. It basically followed this woman who came from sort of a more modest socioeconomic background, African-American, and how this was the second pregnancy. And she knew that there was something wrong very early. She was a mother. She already had, as a matter of fact, when she went to the hospital, she would, finally, there were all these problems, long story short, all these problems. And then the final time that she went to the hospital, her 2 little boys, were waiting anxiously for her to come home with the new baby. And unfortunately, she lost the baby, right? And repeatedly, she kept saying, this doesn't feel right. Nobody's listening to her. Nobody's listening to her. And at the end of the article, they highlighted Serena Williams, is it Serena or Venus, that had the pregnancy. Serena, is that right? Yeah, okay. So she had a history of blood clot to the lung. She knew that she'd had this history. So she had the baby. And of course, we know that women in the postpartum phase, about 6 weeks, are at higher risk of having a blood clot. So she was having those symptoms and nobody would listen to her. They kept saying, no, it's anxiety. No, it's all in your head. Oh, you're a first-time mom. She's like, I've had a blood clot. I know what this feels like. And that's exactly what she did. So clearly there is the component of sort of the structural racism, right? The medical apartheid. Yes, classism can play in, of course, but for Black women, it is that and some. But now let's kind of put all this in the context of COVID, because I think what COVID has done collectively, at least for mainstream America, many people have sort of been surprised, if not shocked, to see these inequities. And then, of course, anybody who's working in this space knows that these inequities are not new, right? COVID is just the latest example. So let's sort of frame our discussion. What is happening in the space of maternal and child health now in the District of Columbia since COVID began?
I could share just from the community health center perspective, some of the challenges and some of what they've done to meet those challenges, because they have been at the front lines of, originally testing for COVID and treating COVID, but also see many women in the city for prenatal care. And now they're in the phase of vaccinating against COVID and still doing that work. All this time while trying to maintain their appropriate distances and care environments. So they have had to do a massive shift in some cases to telehealth for prenatal care. They still see patients, with who they need to see in person. They still do see them in person, but they did a lot to provide sort of kits that women could take home so they could do a lot of the care remotely. That protected women from not coming into settings where they could get infected. And it made it possible for them to continue to do things like vaccinate. But it has been a massive change for care delivery. You all are directly care providers. So the health system does not have a reputation for rapid transformation in the past. And I know you know this, but I think the health system learned something about itself through COVID, which is that it can change rapidly. And my goal in this moment is to say, all right, what else can we change rapidly? Because we found out we can,
yes.
And so let's talk about that. What else?
So Dr. Thomas, I mean, you are doing the Safe Babies, Safe Moms. Give us an idea of how DC, what is the status of maternal and child health? And tell us a bit more about this initiative that you are part of, or heading, I should say.
Sure. As mentioned in earlier parts of the conversation, maternal and infant mortality, there are disparities by race. Black women fare worse when it comes to those particular indicators. And for DC specifically, we're worse in the nation. And so
Can you stop and say that again? Because people
Yeah.
may be shocked. Here we are, the capital of the richest country in the world. And can you say that again? Where are we in the nation?
We're the worst. We have the highest disparity in maternal and infant mortality in the nation. And when you even look within DC by ward, there are disparities by ward, with a lot of the issues in wards 5, 7, 8. But when you compare that to like Ward 3, for example, it's a stark difference. And so, as you mentioned earlier, the Clark Foundation really wants to change that and has a parent-child health initiative that they funded, which includes our Safe Baby, Safe Moms initiatives. There are other initiatives that they have in play with other health systems and community partners, but where our initiative led by MedStar is called the Safe Baby, Safe Moms initiative. And for us, we are targeting removing those disparities, at least decreasing them. Hopefully we get to 0 along the way, but decreasing disparities, focusing on women who deliver at MedStar Washington Hospital Center. So we take a different approach. We take an integrated, multi-generational approach across not just the prenatal and delivery space, but 5 different time points in that perinatal period and even earlier and beyond. So we look at preconception and really providing services to women who, if they were to get pregnant, would have an adverse outcome. And so really trying to give them resources, training, care that they need in order to prevent something from happening later. And then we also, of course, look at the prenatal space and do things like connect them with a pediatrician, make sure they have those connections. We do, across all of the time points, screen for social determinants of health, behavioral health issues, do care navigation, because navigating healthcare is difficult for most people. And so, add on needing to be pregnant and care for children and all the things in that space that go along with that. So we add on that. Of course, we focus at delivery, pain management. There's actually disparities in the care delivered when it comes to pain management. So we want to focus on that immediate skin to skin contact with mom and baby afterwards. We focus in the postpartum space on grounding and making sure visits that need to be scheduled are scheduled, those kinds of things, a good transition back into home, and providing extra services around that. And then 0 to 3, we make sure the mom, the baby, the family hit those developmental outcomes, are thriving as a family, and so that we can have a healthy child at the end of the day. And so we do that by bringing together 4 of our clinical service lines, one of which is led by Dr. Patchen with Women and Infant Services at Hospital Center, but also community pediatrics at Georgetown University Hospital, child and adolescent psychiatry, family medicine. We also bring together 2 amazing community partners with Community of Hope and Mama Toto Village and work together. It's amazing that over the last year, it's a 5-year initiative, hopefully longer, but over the last year, we've been able to break down silos within our healthcare system, but across with our community partners, and even broaden that out and have advisors like the Rodham Institute on our strategic advisory board and the mayor's office and so much more advising. Because as you said, Dr. Gigi, earlier, this is one of those initiatives, this is one of those topics that is so important that competition has to go out of the window. We have to do this together to tackle such an important issue. And so we're excited about that. We have a strong research component because when this works, we want to be able to show other folks how they can do something similar and what conditions in their organizations and their climate would promote or maybe be barriers to some of the things that we do, but we want to give them that information up front. And so we leverage the power of data science. We leverage the power of implementation science, which is what works and under what conditions. We also want to test some different payment models, some of the barriers to doing a lot of these things, wonderful midwifery care, doula care, community health workers. There are payment issues with that today. And so we want to test some payment models and maybe we can get that to change. We also have a strong biostatistics and informatics component, a lot of data that needs to be analyzed at the end of the day. But one of the most critical pieces that we have is a health equity focus. As you mentioned, you know, we have this avatar, Loral might smile when I say it, but she's called Young Fertile Angela. And it is me if I was younger, fertile. And the fact of the matter is I won't screen for any social determinants. I won't screen for poverty issues, education, access issues, any of those things. I'm relatively healthy, but yet, as you mentioned, I am still at higher risk for an adverse maternal or infant outcome than my less than high school educated white counterpart. And so we have—
Wait a second. Can we say that again? Because that is a statistic. So you, with your education, and tell me what your last degree was?
A doctorate in public health.
A doctorate in public health. You are, you know, a professor at a university. You are, you know, highly educated, upper middle class. So your outcome would be worse than who?
A less than high school educated white counterpart.
Wow.
It's a pretty bleak statistic, right?
Right.
And so, yes, we can move the needle on disparities by addressing access and transportation and food insecurity and all of those things, but we won't eliminate it. And it's to Laurel's earlier point, it's the system with which I, or young fertile Angela, lives of structural racism that impacts our outcomes. So we do things like implicit bias training, looking at the role of the trauma experience and training our providers and staff on what that means and how to better care for our families as a result. And it's not a one and done. It is an ongoing conversation to move the culture, to move the needle in how we treat the people that we are designed to, that we have to care for in this critical piece of American. And so that's
yeah.
I could talk about it all day. So you got—
Yes, no, and you know, I'm just so glad that you're sharing, because you know, babies, babies, look, and I'm of Egyptian heritage, African culture. Do you realize when a woman is pregnant, her status is elevated? You are never supposed to upset a pregnant woman, ever, 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 because of, you know, mother as goddess is just so key. And what's sad to me about the US system, as opposed to some of the other, let's say, westernized systems, my oldest niece has 2 babies. She and her husband live in Paris. Do you know that they would actually send a masseuse for both of them when she was pregnant? The amount of time that they had off, a lactation consultant. I mean, I remember when, you know, I was program director and they say 6 weeks or 2 weeks or 6 weeks off to have a baby. I'm like, what? In Egypt, now maybe this is the other extreme, but 2 years for anybody who has a government job is paid leave, 2 years, because that corresponds with nursing, right? So I think that there is something more in terms of the American system that has to do with not valuing, I mean, the woman or the child in the way that she, or the family. I mean, I think that, you know, I mean, we could talk philosophically about these things, but that has to be looked at because these are policy issues. These are systems issues. So yeah, I mean, it's a lot.
I would just jump in just as a point of comparison. Last year, I think it was, DC passed legislation that extended Medicaid coverage for 12 months postpartum for women who might not otherwise qualify. Passed that legislation. But DC has an interesting thing where you can pass legislation, but if you don't fund it, it's just passed, but nothing changes. So they didn't fund that 12-month postpartum coverage. It was going to cost in year 1 $361,000 for the DC share of that. And we couldn't find it. We didn't do it. So you're talking about 2 years of paid leave and all of that. And we couldn't find $361,000 to fund 12 months of postpartum coverage for women. So I think, yeah, we have an issue here about valuing all women. And I just wanted to share that because it's such a contrast.
So there was a question on the question and answer. I mean, we in DC, about 97% of people have coverage, insurance coverage. So Dr. Patchen, why are our outcomes the worst in the country? What is it about DC that makes us so far behind?
Well, I think that there's a lot of different kinds of answers that you'll get to that question. I think if we, these kind of deep inequities, they take a long time to develop. They're not things that, sort of occur overnight. I mean, I would look at redlining as being one of the first sort of policy steps that set us up for the outcomes that we currently have today. And if you sort of map over in the district where we see women and families really suffering from multiple challenges, and as Angela pointed out, these are not challenges that arise from income and education alone. They're challenges that arise from how we have made decisions around structuring our relationships with one another in our communities. So if my answer would be, one of the reasons is that we had some very hard boundaries in this city at one time. Think about how the DC metro system was built and who it was built for. So, our answer to this challenge is not likely to arise from a new medication or a new fancy medical device. The way forward is going to be, really grounded in taking steps to restructure how we think about providing care. I love the piece around the duration of follow-up in the postpartum period, because, traditionally historically, many people are doing much more than this now. But, when I was trained 20 years ago, it was a 6-week postpartum visit. And I was really fortunate to have grant monies to support a good part of my work early in my career with teen parents. And one of the things that allowed me to do was to see my patients much more frequently in the initial postpartum period. And for some, it was 1 week after they delivered, and for others, it was 2 weeks. That was more typical, and then 6 weeks, and then 12 weeks. And being able to check in more frequently allowed us to recognize the need for support and assistance a lot sooner than we would have otherwise. But honestly, it also just facilitated an ongoing connection with the person's narrative of making this huge life transition. So I agree, Tricia. I did not know how little it would have cost to fund that initiative. So I'm really glad that you laid that out for us, because it really does highlight how some things really are doable and achievable. I mean, that amount is something that we can certainly, that's a doable amount. That's not, like you said, it's not 2 years of leave.
And I think those big structural changes that and the inequities that developed in terms of where we allowed people to live or thrive or not that work has to continue and needs to grow bigger. But in the meantime, there are mitigating things that we can do. So the 12 months postpartum is a mitigating thing. Making doulas reimbursable is a mitigating thing. One of the things our study found was women didn't always know what was available. And midwives, where they are, they may not be able to go find women to tell them about themselves, but that's work that doulas do. you know, and community health workers do. But right now, neither is reimbursable in Medicaid. And Medicaid is a huge player as a payer in our city. Because we have such robust coverage, that means a lot of people are on Medicaid in the district. So what Medicaid does really matters. So I think like big thinking on aggressive change in how we relate and live in this city. Yes. And yes to these mitigating ideas.
So I want to, I'm sorry, I just wanted to bring up a positive model, two positive models. So Dr. Javaka Moore is a Howard-trained OBGYN. He's of Trinidadian heritage, had 5 OBGYN clinics all over, sort of in the Maryland area. He was actually discouraged from opening up a clinic in DC, partly because of the malpractice issues. And he said, you know what? He had gone overseas. He does work in Ethiopia, Eritrea, Nigeria, and then came back and started to learn about the great inequities here in DC. And so he opened up a clinic actually at the United Medical Center office building. He's got a 0% maternal infant mortality and a 3% C-section rate. And he has what he does in terms of the model is treating the people nicely and with compassion, and having midwives and doulas and having nutrition services all there. And then I also wanted to bring up another wonderful model, which is at the Developing Community Center that Community of Hope does. I mean, I visited the birthing center a few times. I was just blown away. I mean, for a woman and her family to get the hug of love while the woman is bringing in a new life into this world, to see the rooms that have furniture and, you know, quilts that are handmade, that there's a room for the families to play games, that there's a jacuzzi if she wants to have the baby in the jacuzzi, and that the average time from the time that she comes in and delivers and goes home is like 4 hours. And oh, by the way, people who deliver there can get trained to become doulas. And oh, by the way, they've got a community garden there. I'm like, wow, you know, I mean, that's what to me is the model, right? Because it's taking all of the structural and social determinants of health, you know, and making sure that healthcare is a piece of it, but the economic care, that the food piece, the training piece, the human-centered care is there. So it's not like we don't have models in the city, right? We do. Sure. So I just don't want to be just, negative Nelly here. I want to talk about some of the excellent work that you all are doing. And I want to elevate that because I think it's also really important, because I find that women tend to just do work and not sort of shine or, you know, toot our own horns. And I just want to be able to do that for a while, because I know that there is amazing work that's happening all over the city. So can you each talk about that, please?
I'd love to talk about what we're doing clinically and internally. There's, I think under the Clark Initiative, we've really been able to take practices that we know worked really well for our patients and make them available for everyone. And so a couple of things that I can highlight are, one is we're able to have more time with patients. It's a really key factor. A lot of the listening and the ability to develop a trusting relationship doesn't easily happen in our current healthcare system, because we haven't built we've built an economic model around healthcare that requires an efficiency that does not lend itself to healing and providing a trusting relationship where you can then really get to know the individual and the priorities that they have for their own healthcare. The other thing that our current system doesn't do very well, because of how it thinks about time, is it doesn't allow us to ask those questions more than once. And the gift that we've received from Clark, I think one of the most important has been time with our patients and the ability to ask questions around how things are going and what's happening more than once. So we now have organized our care so that we can have, we make time, we make space for that conversation at least twice before delivery and at least once after delivery. The other piece is that we, I think in general, are moving to a place where we're a lot more open to talking about the ways that our emotional wellness is a real priority for our healthcare overall, but particularly in the maternity space. And so we've integrated a couple of different mental wellness initiatives. One of them is sort of group-based, and others are individual, one-on-one. And then we also have co-located therapists and psychiatrists for women that are in a space where that's helpful and desired. I think another piece of our work that, particularly with this initiative, that really should be highlighted is we're developing a medical legal partnership that we anticipate will be highly focused on food insecurity and housing. Housing is on my mind a lot these days. And I think that's going to be pretty critical for a lot of our families. And it's, we've been in a planning phase for the last 6 months, and from what we found, I think we believe this is the second medical legal partnership focused on maternal welfare in the country. There's one other we were able to find in Ohio. So we're really excited to bring that into the network of services that we have as well.
You know, you talked about housing. We actually, the Rodham Institute was trying to be helpful to the residents of Brooklyn Manor, who unfortunately are all going to be displaced. They just lost their appeal. 50 multi-generational families. It's estimated that in the United States right now, 60 million Americans are at risk for being displaced. And, you know, we were talking about redlining earlier. I say that in Washington, D.C., it's like a game of musical chairs where every time one chair is removed, and it seems like African Americans are the ones that always get left behind, right? I mean, the oldest Black church in DC is Georgetown, right? And then, you know, people keep going around and around in terms of circles, but housing as really an urgent, emergent, structural and social determinant of health, especially in the era of gentrification. We found that people are not repairing the air conditioners. So there's mold that's going on the walls, that the kinds of practices to kind of push people out and what that does to the mental health and the strain, you know, is just unbelievable.
Every woman that we interviewed for our report had some kind of housing instability during her pregnancy. You know, it's very, very challenging and creates a lot of disruption in care, a lot of challenge for families.
Well, and there was just a report that came out where I think it was threat of eviction was linked to early delivery for women. And they were able to kind of look at it very closely and intensely because of the high rate of housing instability with COVID. So, you know, there's clearly there's a real synergy with the social determinants and outcomes. And then when you layer on top of that, the way that we other Black women and particularly Black motherhood, I mean, I think that's a component of this conversation that maybe we could also highlight a little bit, is that it is that layering effect, but it's also the particular way that we don't value Black women as mothers in this country, and that our ability to really lift up and celebrate Black motherhood itself is, we're real challenged in that regard. And I think I'm real grateful to Beyonce and Serena for telling their stories, because I think it's also really empowered women to start to ask more questions and to, you know, even be much more tuned to things like blood pressure in the maternity space.
Could I share a little bit about our Equity Action Lab?
Yes, please.
Because I think it really speaks to engagement with Black women and bringing them in, you know, sort of making space for them to be part of solving these challenges, that we're not creating innovations in a vacuum. and so our Maternal Health Equity Action Lab brings together providers like Loral with women who have had recent experiences in our maternal health system to think about how it needs to change. And so I think one of the things that we need to do more of and do better is for those who are most impacted by inequity, are we making sure they have a voice in the changes we're trying to make to the system? And how are we better driven by those approaches? One of the things I've learned from being part of the maternal lab, there's a 6-woman context team. I just feel like we must be missing so much talent by not making a space at the table, because we didn't find just like the 6 best women there ever were to be part of our lab. We're just like touching the tip of the iceberg of the talent that we could be bringing to the table to solve problems in the health system. So as you can tell, I'm a huge fan of the model, but because I see how it works and I know what we're missing in not bringing them forward in that way.
Well, and then, there, as you all know, I don't need to tell you, but study after study after study shows that when you have as much diversity, and not just in terms of ethnic diversity, but diversity in terms of experience of people that are at the table when the model is being created, your outcomes are going to be better, plain and simple. So there was a question in the chat about what is the role that churches can play, or the faith-based community can play in improving the health of mothers to be, of babies to be, and babies and families. Does anybody want to take that? Yes, Dr. Thomas.
But I always, I'm going to disclaim and give it back to Laurel, because there's a component there about teen moms, and I'm just more interested, just because of her work in the teen mother space in DC, how much intersection or experience that working with faith-based leaders came into that work. But being a faith-based leader in my own community and having history as a teen mom, I'll try to speak to it. One of the things that was super helpful for me as a teen mom was to feel support. Now, I'll say that in a faith-based community, there is a camp that is judgmental, and there's an element, especially if you're in that community. And as a unwed teen mom, you now have to show your face as pregnant, if you would. Just diminishing that shame or feeling the support to get the shame to come down, because there's already that stress level. So having a community of support is really important. I would also say that, so as a leader now on the other side of that thing, I pay that forward. I make sure that we are just as excited. We put the resources behind. We do our own version of assessing any social determinants that might be there, and pull together as a community and rally around the families to make sure they have what they need. And we do that not just for our teen moms, but we do that for any mom, and not just our unwed moms. We do that for any family. We make sure they feel supported as a unit, whatever that unit looks like in that maternal space, so that we walk away. No one wants to walk away with a harmed or unfortunately dead mom or baby. And so we want to make sure that there are healthy lives at the end of it. And so support, another thing that just individually is helpful when you belong to a faith-based community, is that you do tend to get tools that help you with stress, and help you with mindfulness, and help you with social support. And also, you also get, help with access to appointments and those types of things. It's a community. So I think the answer is doing more community for your community members as faith-based organizations.
Well, Dr. Thomas, I have to tell you about a project. Does she know, Laurel? BCPCA, in partnership with Children's and Howard and MedStar and a range of other organizations, has launched a network called DC Next, which stands for Network for Expectant and Parenting Teens. A huge component of that project is a real pushback on stigma. Like, what did we ever gain as a society from stigmatizing? You know, what might change in the lives of young parents if we never went there and we only just ever fully believed in them as parents, as learners, as citizens of our world? So I will be calling you, because we are going to be, so I learned something today that I didn't know, and I would love to engage you in that. Sorry, Gigi, I didn't mean to jump in, but the whole time she's talking, I was like, what?
It's okay.
Yeah.
Actually, we actually have a representative next week that's going to talk more in depth. So for people who are on this webinar, please join in next week. So we have a few minutes left, and I want to make sure that each of you has an opportunity to bring up whatever I may not have asked you about, because this has just been a very inspiring discussion. And I feel like whatever problems that we have, if you three ladies are part of the people that are trying to solve them, they will get solved. So we'll start off with you, Dr. Patchen. Any closing remarks?
Just that I'm really excited to see what we've done in DC over, these last several years. I mean, the outcomes have actually been pretty stagnant for a long time, a couple of decades in DC. And so for me, it's just a very welcome moment to shine light onto, and also to lead the way. If we're able to make positive change in maternal outcomes, it will help us really move forward and create some great momentum for impacting racism in healthcare and disparities, inequities, whatever language people are using, in other areas as well. It's insidious, and it's something that affects all of us. So I'm excited to be working with the community to help us find some at least partial answers.
Thank you. Dr. Thomas?
Well, Loral said it very well. I'm just really excited about the integration of the different people who have been working on this issue for a very long time in DC, yet not having many opportunities or the platform or resources to really come together in a meaningful way to tackle. You have great onesie twosies that have existed, but to bring more folks together and have a platform. Just grateful for the Clark Foundation for their parent-child health initiative, and grateful for the many people that I've just met along the way in this journey, being new to the DC space in this particular issue. It's just been phenomenal to see the expertise, but even more phenomenal to see the coming together. And I just remain extremely hopeful that coming together with those diverse experiences and those diverse lenses that'll really move the needle on our outcomes.
Wow. Ms. Quinn?
So I think that alignment is really key, because there's Clark is doing, there's a range of other things. The Hospital Association just launched a perinatal quality collaborative. This is our time, and it is up to us to make sure that alignment happens, that mutually reinforcing activities, not like, stepping on each other's toes, but that alignment. And DC can do it, because we're small enough. You can be with the people who are doing it to get that alignment. And then to not forget about policy solutions, that there are things that policy does that can structurally change what happens, even as the people on the ground are transforming their practices. So both of those are important.
Wow, ladies, I am hopeful, having spent this past hour with you, and I'm inspired. And, I joke, but it's really not a joke. When you look at a flock of geese who are making that round trip every year of several thousand miles, it's never the same goose that's leading. And I think we can learn from our avian sisters and brothers that to your point, Ms. Quinn, we are big enough but large enough to be able to have different people taking the lead, right? But being gracious to say, you know what, Dr. Thomas, you're the expert in this. I'm going to play a supporting role. But maybe you know, Ms. Quinn, you'll be the leader the next time. But if we all have our eyes on the prize of improving the health of every Washington resident, we can do this. So with that, I'd like to thank each of you. Thank you for your time. And please, for any of you that have not signed up for your COVID vaccination, please do. The P1 very highly dangerous strain is coming through. We want babies and future moms and current moms and dads and everybody in our community to stay safe. Thank you and good night. Take care. Bye-bye.
Yeah.
Bye.